Certainly I am a nurse with a great passion for working with men with prostate cancer as well as their wives, partners, families. I'm also the daughter of a lovely man, Graham, who has had prostate cancer. So I have worked alongside men in my job and have also been through the dilemmas in a personal way as well. So I share that with you today. I'm going to start out by talking briefly about grading and staging of prostate cancer because, as you'll know from your own journeys, it's important to understand grades and staging because that's what influences us healthcare professionals in guiding you with the treatment choices that you have. Gleason scoring has been around for a long time, and it's when we look at the prostate cancer tissue under the microscope and the pathologist says, how does it look? Does it look like a cancer cell that's not too far removed from how a normal cell looks, in which case we call it well differentiated and we give it a low score, or does it look like a badly behaved, fast-growing type of prostate cancer? Has it lost a lot of its normal cell markers, and then it gets given a higher score? And when the system was designed, it was designed with 1 being the lowest score and 5 being the highest score for the cells most badly behaved. And Dr. Gleason gave it as a sum because he recognised that when you look at a sample, you don't see necessarily all the same types of prostate cancer cells. So the first number in the sum is the number attributed to the cell that's most common in the pattern. So if you've got a lot of well-behaved, well-differentiated cells, you'll have a low number at the start of the sum. And if you have a few that are starting to become faster growing, then that is the smaller pattern, and that is the second number in the sum. So a Gleason score, as you'll be aware, is represented as a sum. And originally they thought that sum would be 1 through to 5. But what we found in recent decades in clinical practice is that actually the bottom number is now 3. So the best slow-growing, well-differentiated prostate cancer is actually a Gleason 3. And so the lowest overall is 3 plus 3 equals 6. And so in recognition of that, a group of pathologists from around the world have been meeting over the last few years and have recently come up with a new grading score, which will better represent to you what low-grade prostate cancer is, because it's hard to understand how a doctor or a nurse can be saying to you, you've got the most slowest growing, well-behaved prostate cancer there is, and yet you get a 6 out of 10. You think, well, what happened to all the other low numbers? Where are they? And actually what has happened is, as we've understood prostate cancer better, we've realised they aren't really even prostate cancer cells at all, and that's where they've gone off the sum. You'll see that prostate cancer is just starting now to be reported, and we're getting both things on a report. So it might say Gleason 6, ISUP 1. So this is the International Society of Urological Pathologists. That's where the ISUP comes from, and they are now reporting that the most slow-growing samples, the Gleason 6s, are 1, right through to the Gleason 9 or 10, which is the fast-growing prostate cancers, potentially are given a simple grade of 5. So the sum concept will begin to disappear. So the importance of understanding prostate cancer is not only what does it look like under the microscope, but what stage is it at when it's diagnosed. So is it localised? Is it within the prostate cancer? Is it on one side? Is it on both sides? Because if it is localised prostate cancer, then there is a good chance that treatments will be able to cure the cancer. Locally advanced prostate cancer is just moving outside of the gland into the surrounding tissues. And metastatic prostate cancer, as you know, will have already moved to lymph nodes and to other areas like bones, lungs, liver, brain, those sorts of locations. And it's important for us as healthcare practitioners to be able to represent that information to you, hopefully in a way you can understand, so that you can begin that journey that you talked about, Ian, of trying to make a treatment choice, which is often really difficult. If prostate cancer is localised, then someone will talk to you, no doubt, about having the option of surgery, radiotherapy, brachytherapy, which is the radioactive seeds, active surveillance, I'll talk about these in some detail, and watchful waiting. So all of those 5 choices are suitable for localised prostate cancer, but there will be many things that will influence us and you on deciding which of those will be perhaps the best way for you to go. So stage, we've talked about where is the cancer, how does it feel to the finger, what have the scans told us, CT scans, MRI scans, bone scans, what information do we have about where the cancer is. What is the absolute number of the PSA? Because we know that if a PSA is 50, then there's a good chance that you've got more extensive disease than if the PSA is 5. When the biopsy is done, how many of the cores were positive? So they might take 12 cores. Was only one of those cores positive? Were all of those cores positive for having cancer? And then we look at the cores and we say, well, out of the 2 cores that were positive for cancer, was the entire core filled with cancer cells, or was only 2 millimetres, say, of the 13 millimetre core had cancer in it? Because that gives us information about the extent of the cancer that a scan might not be able to tell us. But we also have to think outside of that purely medical sort of information. We need to think about what your health is like at the time of diagnosis. What other health conditions might somebody have that might be affecting the symptoms that they're living with on a daily basis, but also their life expectancy. Abdominal girth. Your surgeons are reluctant to operate on men who are obese. It is difficult to get to a prostate that sits right behind the bone, so it's right in behind the symphysis pubis here, if you've got a big tummy. And so some of you may have had the experience of a surgeon saying, I'll operate on you if you go away and lose a few kilos of weight. So that definitely influences decision making. If someone has quite severe urinary symptoms already from perhaps an enlarged prostate, so not necessarily the cancer in it, but the fact that the prostate's got bigger with ageing, then we know that radiation might upset those symptoms and cause them to get worse, and surgery may improve them because you remove the bulk of the tissue and help the flow. So that might influence someone's decision. If someone has some bowel conditions, things like ulcerative colitis, Crohn's disease, things that make them go perhaps to move their bowels 5 times a day and they're a loose motion already, then radiation is not really a good choice for them if it's going to upset their bowel further. So it's really important for us to know what conditions men are living with. Talk about health insurance or whether you've got money in the bank, because one of the treatments, brachytherapy, is not yet funded in the public healthcare system. So it really is only an option for you if you have one or other of those available to you. And then just simple things, personality. Some people just like the concept. As you said, if you've got cancer, let's cut it out, get it out of the body. That sits more comfortably with them. Other people don't like needles, hospitals, and would sooner be doing something as an outpatient, which a radiotherapy treatment is. Some people live a long way from hospital. They'd sooner come and have an operation and have to only visit the hospital a couple of times rather than on a daily basis, Monday to Friday, for radiotherapy. Or have to move to a place closer to the hospital for that treatment. So those things again influence decision making, and they can be entirely valid, because often as a specialist we'll sit and we'll put your details into an algorithm from these huge clinical trials around the world and say, well, if you have radiation or surgery, the chances of us curing you are about the same, about 97-98%. So then if we say it's going to be the same chance of cure, then it might come down to these sorts of things that make the decision right for you. So just a brief overview of the treatments because of the time frame. Radical prostatectomy, removal of the entire prostate, some of the surrounding tissue and the seminal vesicles. Can be done in multiple ways, an open procedure, laparoscopically, or also the robotic option. It enables us to assess the tissue, so it does give you the opportunity to have the prostate out of the body under the microscope, so you can see things like, was the cancer contained within the organ as we thought it was on the scans? Are the margins where the surgeon has cut free of cancer? It gives us useful information. You can combine it with post-operative radiotherapy. So if the PSA doesn't go to unrecordable, then you can go on to be offered radiotherapy to the prostate bed. Whereas the other way round, it's hard to find a surgeon who's keen on taking out a prostate after you've had radiotherapy because of the changes in the tissue. The healing would be very poor and the surgical outcome would be very likely to be a lot of incontinence and definitely erectile dysfunction and just not a good option. All treatment choices have the risk of acute, so things that happen straight away, and long-term or late side effects. And so you'll know we talk about erectile dysfunction, we talk about urinary incontinence, we talk about changes in fertility. radical prostatectomy results in a PSA of less than 0.05 if you've had a clearance of the cancer. Okay, so how does that compare to external beam radiotherapy, where we've talked about people, men travelling in for 6 to 7 weeks, sort of Monday to Friday, for a relatively short treatment time, but obviously there's that package around, and in Auckland it's all about finding parking and about travelling in the traffic. It can often be a safer treatment choice for men who have health issues that are affecting their quality of life, maybe heart problems, those sorts of things. So it's a good treatment choice if you're not suitable for surgery, but it is also a good treatment choice, even if you are suitable for surgery. Okay, brachytherapy, as I say, only available in the private sector. Radioactive seeds implanted into the prostate. They have a little sort of halo of radiation comes out from each seed, and so the urologist very carefully places the seeds next to the cancer focus, and therefore that is the part of the prostate that gets radiated, so it avoids that collateral damage of the surrounding tissue. So it's a very precise treatment. It's prescribed for individuals according to where their cancer focus is, but there's a very precise group of patients that it's suitable for. And that price tag, I think, is about right, but it can be a little more or a little less according to the number of seeds that you need. And generally, I'm not sure whether this has changed a little bit in recent times, but the principles are that it's suitable for men with low PSAs, with low Gleason or low ISUP staging that we talked about at the start, small amounts of prostate cancer. It's not suitable for men with large prostates who already have obstructive urinary symptoms that we talked about previously. And the advantages, as I say, is less damage to surrounding areas. You'll have heard a lot about active surveillance in recent times. There's been a lot of criticism of PSA screening because of the fact that it diagnoses often men with very small amounts of low-grade prostate cancer at times. And so then there was a move towards wondering if we were over-treating those men. Was that prostate cancer ever going to limit or affect their lifespan? So active surveillance has become very popular, and certainly something that we talk about in great detail with men with low volume, so small amount of low-grade prostate cancer, is a very important consideration when they're making a treatment choice. So active surveillance is when you defer treatment for your prostate cancer with the expectation that you will have treatment if the prostate cancer shows signs of progressing. So it's an active way of monitoring you, accepting that you are a gentleman who would benefit from treatment, and we're trying to time the treatment at the right time so that you can live for as long as possible without the side effects of treatment, and potentially never have treatment if that little focus of prostate cancer never changes. So you're looking at men with very low PSA, low Gleason score, small amounts of disease, and the active surveillance protocols aren't agreed internationally or even nationally, but they always include regular PSAs, regular rectal examinations, usually a rebiopsy somewhere within 12 months of the original one, to make sure that you haven't had a focus of perhaps higher Gleason prostate cancer missed at that original diagnosis. And there's a move now towards including multiparametric MRI scans that have recently become available to us. These are proving to be useful for picking up high-grade prostate cancer foci, which is what you don't want to miss. So it's safe to be on active surveillance as long as we haven't missed a high-grade focus. And that seems to be the strength of multiparametric MRIs, but it's still new technology and it's still not available everywhere. It differs from watchful waiting. Watchful waiting tends to be for gentlemen who have a lot of other health issues, and we say, okay, yes, we have found some prostate cancer. Let's monitor that with regular PSAs, perhaps with digital rectal examinations. We're not going to rebiopsy. We're not going to be doing lots of scans unless someone develops a very high PSA or symptoms, because there are usually other competing health issues that are more likely to be important in that man's lifetime. So it doesn't mean that you're left out there on your own. You still need support and information, but it is a very valid pathway in men who have poor health. So So just finishing up by looking at metastatic disease, because unfortunately some men are diagnosed at the time when the prostate cancer has already spread outside of the prostate. And the most common place for that, as you'll no doubt know, is in the bones. Other men will have a primary treatment like radiotherapy or surgery and will go on later to develop metastatic disease because that original treatment with a curative intent didn't actually cure the patient. And the standard of care for metastatic prostate cancer that's spread outside of the prostate, is hormone therapy or androgen deprivation therapy. But as things are changing all of the time, and this is another recent thing with a couple of very large international studies, the Chartered study is one that you may be familiar with the term. It showed that with men diagnosed with metastatic prostate cancer who are in good health, if they're diagnosed with it right up front, so not developing it later, but right up front, that there is added benefit from adding in chemotherapy, 6 cycles of chemotherapy right at the beginning. And it showed, I think it was about 14 months longer life expectancy in that group than those who had just hormone therapy alone. So it's something to be asking your specialist about if you're diagnosed up front with metastatic disease, because there's a very precise group of men who would get that benefit, and it won't suit everybody. So what is androgen deprivation therapy? These are the medicines, the injections, the tablets that Ian's already started to talk about, and I've got some names of them shortly. We know that by reducing the testosterone level in men, we're kind of removing the food source, I guess, the stimulant to the prostate cancer cells dividing and growing. So we know that it delays progression of prostate cancer, it prevents complications, and it palliates or relieves symptoms. And there are 2 major classes, and they both work to block the effect of testosterone. The injections work by telling telling the testicles to stop producing testosterone. And the tablets tend to work, just broadly, they work by blocking the action of testosterone at the level of the prostate. So they don't turn off the production, but they stop it kind of in a lock and key way, getting to the prostate cancer cells and stimulating them. So some big words there. The LHRH agonists are the injections. That's the Zoladex, the Leukerin, the Eligard. So they're the ones where the brain is telling the testicles, stop making testosterone, reduce the levels right down low, and that will stop stimulating the prostate cancer cells. And the anti-androgens tend to be the tablets, and there are some broad groups there that work in slightly different ways. Now, unfortunately, the hormone therapies will eventually stop working. However, that can be decades, and it can sometimes, unfortunately, be 18 months or so. We're all individual. The prostate cancer cells respond differently in different people, and there is information, I guess, about that we still don't fully understand. We do know that when we remove the source of testosterone, that prostate cancer cells are actually capable of making their own small supply. So we're learning those sorts of things all of the time. So we have a thing called castrate-resistant prostate cancer. So that's saying that despite testosterone being at castrate levels, so as if the testicles had been surgically removed, then the prostate cancer cells will continue to grow. And in that environment, it's an exciting time, I guess. There's a lot of new medications coming through, and you'll see on that list there, and I'm not going to go through them all one by one. Many are funded, some are not yet funded, but I'm sure that in the future will be. And these medications work in different ways. Some reduce the testosterone level to even lower. For example, abiraterone or Zytiga, as you referred to it, Graham, which is its marketing name, will reduce testosterone even lower than anything has before. Whereas chemotherapy, for example, works on a different mechanism of action altogether and is not about hormone therapy, it's a different mechanism. So the urologists and the oncologists will work with you if you develop castrate-resistant disease to look at which of those options is going to be the best treatment choice for you, and weigh up that side effect profile with the effect that it's likely to have on your prostate cancer. So I can see, and I remember with my dad, that when you get diagnosed with prostate cancer, there's a lot of information, isn't there? And it's important for you, I think, to have that understanding of your Gleason score, your stage, but also the way you feel about life. You know, what is important to you, what are your goals, so that you can work with the team to choose the treatment that's best for you. And then once you've made that choice, I feel it's important to be positive about that, because you're never going to be able to do the what if. So if you do have side effects from the surgery, you're never going to know what would have happened if you'd had radiation or vice versa. So it's kind of like committing to that treatment, being positive about it, and working through whatever lies ahead with the team that should support you, which is us. Thank you.